Good afternoon, and thank you for joining us for this COVID vaccine town hall. My name is Laurie Moody, and I'll be your host for this afternoon. There's a lot of questions out there still about the vaccine, so we brought together a panel of experts to kind of answer some of the questions, give us an update and some more information on what's happening. I have a list of questions here with me, but please feel free to add your own questions into the comments, and we'll get to as many as we have time for. On our panel of experts today, we have Karen Hammersmith with Reno County Health Department, Dr. Scott Polly with the Hutchinson Clinic, Dr. Keck Hartman with Hutchinson Regional Healthcare System, and Amanda Hollett with Hutchinson Regional Healthcare System. Thank you all for being here and joining us. All right, so we're going to jump right in. The first question is for Karen. Can you please explain the phases of the vaccine distribution and where we are right now?
Yeah, thank you. We are in phase one. KDHE put out a 5-phase group for us, and right now we're in phase one. So what that means is we are strategically working on getting healthcare workers, residents in the long-term care facilities, and then critical workers that are responsive to the pandemic. So that would be your emergency management and EMS, those people that are working on the front lines. And then long-term care is also being taken care of, and that is through Walgreens and CVS. So we've worked together to get several different groups vaccinated all at the same time. We have received in close to 3,100 doses of vaccine just to those healthcare workers associated, and we have distributed most of those. This week, I believe it was Wednesday, we received in our second dose to get this in. It's a 2-dose series. So we got the first doses in for this group back at the end of December. We started on December 21st here at the health department with our vaccines. The hospital had it about a week or two earlier than that with the Pfizer, and then we got the Moderna. So we have 28 days, and that came in. We get to start next week on that. That's when the first 28 days is up. So we will get the second round of this first phase in. The hospital, I believe, has completed that as well. And then we get to move on, and that's what everybody is wondering, you know, when are we going to be able to do that? And it's really up to when the vaccines come in. Who is in that next phase, which would be phase 2, would be persons aged 65 and older, congregate settings. So that is like in our county would be areas like tech that live together. And then also if you have a prison and those types of things, you want to get people that live in areas because the virus spreads very quickly in those areas. And we saw that, which the Hutchinson Correctional Facility outbreak, and that's been across the country. Those things have outbreaks, and that spreads into your community very quickly because those people that are working there are then exposed every day when they go to work, and getting the proper PPE in and using it correctly is difficult as well. So they do want to get into the congregate settings, and then high contact critical workers, which is another area that we have identified, specifically teachers, as well as some other people in our community that are really around a lot of people, and it's critical with our infrastructure. If we go back to essential workers, almost everybody's going to qualify as an essential worker because you know, it takes all of us to build this community. But we do prioritize those, and we will look at that as well. So it goes to the high contact critical workers, and definitely as we're working with the providers in our community, we want to get those that are 65 and older that have pre-existing conditions, and that's what we're moving for. The next phase is move on to those age 16 to 64 with severe medical risk and other critical workers. And then towards summer will be that group that are age 16 to 64 with other medical risk. And then the next phase they have put out there is the rest of the population. And children is asterisk because at this time we don't have a vaccine that would be designated for anyone under the age of 16. The Moderna is not available for anyone under the age of 18. But I'll go ahead. I think I answered that, and I'll send it back to you, Lori.
Thank you very much, Karen. Okay, Dr. Polly, could you kind of give us a little overview and explanation about the vaccine itself, including its effectiveness and safety?
So I might start with the advances that were made in a rapid fashion with these immunizations, given that this virus is completely new. These immunizations, these vaccines are based off science that was already there. So there was really the building blocks for the researchers, and just putting it together for the specific virus was the initial hurdle. And I will say these have been really studied about as much as any other vaccine. We've just compressed it into a shorter time. We won't have long-term data on them until we have a long duration after their administration to know. Thus far, in the sample sizes of volunteers for the initial studies, it's been shown to be quite safe. And in the hundreds of thousands of individuals across the country so far, that efficacy data has held true, or safety data, I should say. As far as efficacy, people will see those numbers 90, 95%. That's based on getting the 2-dose series. We get a lot of questions on how efficacious is the first dose. I'll see numbers ranging from 50 to 70%, but that becomes a more difficult conversation and an in-depth conversation when we start defining what efficacious is. From the studies I had seen, it's mainly based on people's symptoms. A decrease in their symptoms is considered effective. So it all depends on what we're actually measuring. To sum that all up, I'd say there is partial protection with the initial dose, but it's very important that everybody get the second dose to get us to the level of protection that would really protect the individual and our community. That becomes a big conversation because many will ask, why aren't we just giving out one dose to everybody? The fact is that would really be inadequate. So we're going to stick to the 2-dose series like has been recommended in the studies. And with that, we should see benefits for the community.
Okay, I'm going to follow up with the question I've gotten. After I go get my second dose, I mean, how soon can I go see grandma and grandpa? Or is it, are they going to be protected? Am I protected? Or how long do we have to wait?
We don't have good data yet on if this vaccine stops transmission. And that's going to be a real kind of gut punch for a lot of people. The intent of the vaccine at this point is to decrease people's severity of symptoms, hopefully avoiding hospitalization and death. In the future, we might find that this vaccine did completely stop us from having the virus and transmitting it, but at this point we don't know. So let's use an example of myself who's fully immunized. I could become infected with the virus, have minimal to no symptoms, but act as a carrier of sorts to seed the virus to those in my home, my loved ones, etc. So at this time, the recommendations for those who are immunized is the same for those who are unimmunized. Wear a mask, distancing. In addition to that, it's still quarantining if you're exposed. This vaccine at this point does not get you a get out of quarantine free card. I would love to say we should do that, but this is what evidence-based medicine looks like. We don't make assumptions. We base our recommendations on what we know. And until we know that this vaccine would stop or inhibit a person's ability to spread it to those around them, we're going to hold true to the measures that have benefited our community so far. So kind of a long answer, but the answer would be, short answer would be, keep your distance from grandma and grandpa, wear your mask, protect them. Hopefully when they get the vaccine, that'll be what protects them directly.
Thank you, Dr. Polly. I think this one's probably going to Dr. Hartman, but who all should get the vaccine?
You're on mute, Dr. Hartman. I think you said everybody.
Everybody. Dr. Hartman, you're muted.
Can you hear me now?
Yes.
Yeah. The short answer is everyone, although Neither of these two vaccines are approved for ages under 16. They might be eventually, or some of the newer vaccines that have yet to be approved might be indicated for under age 16. So there's an age requirement. People that should not get the vaccine are persons that have maybe had a severe reaction to a vaccine in the future, or a severe reaction to any injected medication. There'd be a concern for allergic reaction to one of these vaccines. So in that case, I'd say please consult with your doctor and have that discussion. Pregnant women, it's as far as we know, safe for pregnancy. Definitely safe for breastfeeding women with lactation. There have been many people in the trials that inadvertently became pregnant during the trial. No adverse outcomes have been noted, but of course, still following those people quite carefully. But it seems right now, it seems to be safe in pregnancy. And we do know that active COVID infection during pregnancy is dangerous. So you have to weigh the risks of becoming infected while pregnant versus the potential risks of a vaccine. So I don't know if I've missed any classes of people with immunosuppression already for one reason or another should be able to take this vaccine. We're not sure about the effectiveness in people with underlying autoimmune disorders, but we also aren't aware of any potential adverse reactions from taking the vaccine.
Okay, I think that answered mostly. We had a question from a viewer who has a son with a compromised immune system, and they want to know how soon can he get the vaccine and what phase that might be. Or Karen might have that answer. I guess it depends on age too.
Yeah, I might have a little answer to that. It depends on age. So let's assume her son is over the minimum age for the immunization. He should get it unless he has one of the contraindications, which would be, like Dr. Hartman said, history of bad anaphylaxis, which would be an allergic response to immunizations or injectables or to any of the ingredients in this. Those who are immunosuppressed really should get it. Like Dr. Hartman said, we don't see any potential increased harm for them. The only concern would be if they are immunosuppressed, they may have a less robust response and then less benefit from it. But then again, these individuals are inherently at higher risk to the virus. So if we can get them the defenses offered from the vaccine, it's a benefit. As far as when, that would depend on the phasing that Karen and yourself kindly showed, as also where that individual would fall as far as risk within their specific age group.
Great, thank you very much. Amanda, so you're among the group, the healthcare workers were the first to get the vaccine. What have you seen kind of from your staff members' experience, or are you seeing any side effects or things like that from the vaccine?
Like Karen said, we've given Pfizer round 1 and round 2, and we've given the Moderna round 1 to staff so far. And honestly, it was kind of spread across the board. We've seen folks that had absolutely no reactions to it whatsoever. The occasional person with a sore arm at the injection site, which really didn't last that terribly long. But we have had folks that have had the body aches, the fever that comes with that. But it's been 24 to 48 hours typically is what they're seeing that for. We have had a few folks that have had COVID in the past who were more likely or had reported a lot more symptoms of that same body ache, fever, just general not feeling good, feeling tired, more so than the folks who hadn't had it previously. But we've kind of had it spread across the board with our team here.
So I was trying to read something from Karen here. Dr. Hartman, so I think you guys mentioned this a little bit, but how long are we going to have to wear a mask, even if after we're vaccinated, or do we still need to wear a mask?
Yes, we do need to keep wearing masks. For how long? I don't know. I hope not much longer. Everybody's tired of this. As Scott mentioned, the vaccine does a really good job of preventing symptoms from infection, but we don't know how well it prevents infection. And I don't know if that's a difficult concept to understand, but despite being vaccinated, it may still be possible to get infected, be a carrier of the virus, and therefore contagious. So even though you've been vaccinated, or even if you've had COVID infection in the past and are at least temporarily immune, still wear a mask to avoid becoming a carrier and a vector for spreading it to someone else. So you'd hate to, we need to continue with these precautions until we completely stop virus transmission throughout the population. The vaccine is one of our best ways for doing that, but until enough people get vaccinated, then we need to continue with precautions that we're currently asked to perform, like mask wearing and distancing.
Thank you. Karen, we're still getting a lot of questions. Can you explain the process for getting the vaccination once it's available?
Yeah, we are working with a collaborative with the Hutchinson Clinic and Hutchinson Regional Medical Center, Prairie Star Health Center, as the vaccines have come in to our entity. So we're working together as a huge collaborative to look at what we can do to get this to citizens of Reno County. Emergency management has plans, and they've been working on those plans for years. So they've got a kind of a set way that you would provide immunizations or, dispense any kind of medicine that they have practiced. And so we're looking at areas in town that we could do a large vaccination clinic. But it really is going to depend on when are we going to get the vaccines and how much vaccine is going to come in at a time. What we have been able to do is look at the population. We've got, surveys that we send out, and we do a census every few years, obviously, that everybody participates in. So with that, we can see that we have over 13,000 people in Reno County that are over the age of 65. The chances of us in Reno County getting 13,000 doses in one shipment is probably never going to happen. So then we have to look at how much are we going to get in and how are we going to utilize that. So we're certainly looking at large pod plans, is what we would call that. And then we would focus those to those groups that we really want to get. The Hutchinson Clinic has an EMR system that they are able to pull those patients out and look at the people that have the highest risk factors of the virus taking a toll on their body. So we don't want people to get sick. And that's why that would be a targeted group that we would get to first. And then we could manage that. Prairie Star would be able to pull their people out as well. And then if they're in that area and then do not see a provider, we would be able to still get to those people. But we're working on those ways in a collaboration to see what we can do to get the highest populations. We know the school districts, so we know the teachers and those groups that are in high contact critical care areas, but it's that high population that we are going to want to target in phase 2. Just to let you know what happens as far as when are we going to get the immunizations, we look every single day. There's a website that we're looking on that we order our medication through. It's WebIZ through Kansas. And we look every day to see if an order is coming because we are just as anxious as everybody. And I know that I looked for the second dose that should have been shipped to us every single day up until the day that, we actually received it. Never did get any shipment identification or idea that it was coming until I got an email about 9 o'clock that night from the CDC saying this has been shipped to you. It was here the next morning, Wednesday. So we don't know when that next dose is coming. But what I can tell you is that we're looking very closely. We are working. Everybody on this call is on here for a reason, because we're working together. They're working at Prairie Star looking for this information. We're looking, the hospital's looking, the clinic is looking, and we are working to get this out to Reno County citizens as fast as we have it. The last thing that we want to do is wait for the medication to come in to get 13,000 vaccinated at the same time. So as soon as that vaccine's coming in, we're going to plan with whatever we have to either do small groups and divide and conquer, or we best case scenario, we can get a large group at the same time. But we're going to get that vaccine out as fast as we can. So the point is we are telling you what we know, and we're telling you as soon as we know it. Unfortunately, we don't have a whole lot of indication. From our previous indications from KDHE, it said that second phase would be winter or late winter. So, then we're looking at, okay, we've got December, the end of December, we got vaccines in for this first phase. And then this week, which would be the week of January the 10th, we got our second doses in, and that's how they shipped it. So if we go a month from now, we're in mid-February, if they stay on track, or if they are able to push it out, we might be looking a little bit earlier, but I doubt it at this time. But once again, those plans are being made, and we will get that information out as soon as we can.
All right, and viewer Sarah actually wants to know how she's going to be notified once it's her turn. And for my part, I'll tell you to please check our website at renogov.org, and we try to keep that updated with what phase we're in. And of course, we're going to send it out to every possible media source, radio, television, social media, when we move to the different phases. But individually, how will they be notified, Karen?
I think your response was absolutely correct. I think everybody is using all the different social media aspects that we have. Dr. Polly has spoken, and I'll just keep talking, but they have emails for their patients, and I think that they would be sending emails out as well. I know they have a portal. Most EMRs do have a portal, and they're able to communicate with the patients that way, as long as they have an email that's signed up. I think we're going to do anything we can to get a hold of patients. So it may be through phone call, it may be email, and certainly through every communication tool that we have that you have mentioned.
Great, thank you. Whichever doctor would like to answer this about the new variants of viruses that have started to appear. Can you talk a little bit about that, and perhaps does the vaccine help cover all of those different strains?
Can start on that. So far, it looks like the UK strain is going to be susceptible to the current vaccines. I haven't seen as much data on the South Africa strain, but I also haven't seen any indication that it's not vaccine susceptible. But these are questions that the companies and the CDC and FDA are looking at very diligently right now to help confirm that these two strains will be vaccine susceptible. You have any other information, Scott?
No, you know more than I know on that. We have seen good data come out of the NIH equivalent in the UK, like you said, regarding both immunizations being effective against that strain. Time will tell.
My other thought on that is be no reason not to take this vaccine, the two that are currently available. Right now, there's no reason to think that they're not going to be effective. And those currently are not the most commonly circulating strains in the US. So I wouldn't hesitate to get the vaccine based on that concern, because I think in the end, we'll probably figure out that these current vaccines are effective.
Okay, I don't know if you actually addressed this, but we've been getting some misinformation, some about infertility and some different things. Is there any of that you guys want to talk about that you've heard, perhaps Amanda or the doctors in your practices?
I can touch on about it in a roundabout way, and I'll let Dr. Hartman finish. There's no data that I've seen that shows that this causes infertility. Those type of studies would be kind of prolonged, drawn out studies too. So we just don't necessarily have the time. Again, we did have individuals during the studies who inadvertently became pregnant. So that would point away, at least in the short term, from that theory. Additionally, the American College of Obstetrics and Gynecology has gone a step further to say that these immunizations should not be withheld from expectant mothers or breastfeeding mothers or those who might become expecting. They draw those conclusions from, like Dr. Hartman said, the known risks of the virus. So the risks of the virus to an expectant mother or breastfeeding mother is, at this time, appears to be much higher than any risk from the vaccine. So that group, again, this is obstetricians and gynecologists, are recommending for those patient groups to receive the vaccines.
I'll say, in addition to that, I was just looking on the Bloomberg site. As of yesterday, there's been almost 12 million doses of these vaccines given in this country as of yesterday, and 35 million doses worldwide. So we're not seeing reports of adverse reactions that we didn't already know about. And if adverse reactions of particular kinds or serious reactions were more prevalent than we thought they might be from the initial studies, that's just not being reported. So I feel pretty confident that these vaccines have a safety profile which isn't going to change much from what we already knew. If things like infertility were a real issue, I think after 35 million doses, we might have some indication of that by now. From a physiologic or biologic standpoint, hard to know how a problem like infertility or pregnancy issues would come up, because although this is genetic material, it's not incorporated into our cells. It gets processed through the cytoplasm. The immunologic reactions happen in that location. This piece of genetic material that's in the vaccine never enters the nucleus of our own cells. Therefore does not get incorporated. After a couple of days of being in the cytoplasm of our cells, it's then expelled, and the immunology takes over at that point. So I think any of these kinds of concerns are more theoretical, and haven't really seen any biological models indicating that it might be problematic in terms of infertility.
Okay. We've gotten several similar questions from viewers wanting to know, they might live outside of Reno County, but they come to the doctor. Do they have to live in Reno County to get the vaccine here, or how does that work?
I'll go ahead and take that. No, they wouldn't necessarily have to worry about where they live at in the county. we're working at populations as far as a Reno County, but we certainly know that other counties, especially the border counties that we live in, Rice, in McPherson, Barton, Harvey County, we have a lot of patients that feed into the Hutchinson Clinic in Prairie Star, and that's where their primary care provider is located at. So we would not refuse that, and neither other county that would be doing something similar that we are should be refusing patients that see their providers that are from other counties. So this isn't a problem that's in Reno County. This is a problem in our entire country and world. It's a pandemic. So getting the vaccine out to everyone is important. So we wouldn't refuse that vaccine if they work, live or play here in Reno County. We want that vaccine to everybody. And that also feeds into our hospital. And Amanda can speak to that probably a little bit more of how many patients they see outside of Reno County, and they still have to take care of them. And it's a regional hospital. So I'll go ahead and let Amanda speak to that a little bit.
Yeah, we do. We see patients from all over the place. We've had them come from as far as Western Kansas. We serve a variety of counties within our healthcare system. And so, yes, we would take care of whoever came through the doors. And if we were giving them to patients, we would absolutely take care of them regardless of the county they were from.
Unmute. We've just got a question from Lynn about, do we know now if there will be booster shots required in the near future after you're vaccinated?
We do not know that data yet, nor is there a recommendation for that at this point.
Okay, Sheila wants to know, apparently Florida has approved a grocery store in the state to vaccinate those 65 or over. Is there any plans for anything like that? I don't know if you even know, Karen, or if our state's doing something similar.
So I think probably what they're referring to, they probably have pharmacies within their grocery stores, which we do too. As vaccine becomes more available, I think that you will be able to see that in every entity. So, and we're actually looking at including pharmacies too, as what they could do to help us depending on the doses that we get out. But they have been vaccinating several different people with vaccines now. They help with the flu shots, and so you can get it a flu shot anywhere at Walmart, Walgreens, Dillon's Pharmacy, as well as all your providers that offer it. So it is not surprising to me that other states aren't utilizing that, and I think that most of our pharmacies have signed up to help. And I think anyone that works in the medical field, we look at these patients that we serve as our patients, and we want to help them in any way that we can. So I think all the entities in healthcare are just working together to try to get this vaccine, which is our new phase, to get out. We've been working as a community to treat the patients with not a whole lot. This is kind of a breath of fresh air, just to have something that might be able to help our providers and definitely our highest risk people that can maybe not contract the virus, or at least have a less severity of it if they do.
I think it's good to kind of segue between the topic of places to administer and supply. We could have a million places to administer this vaccine, but if there's no vaccines, it doesn't serve any purpose. Our problem locally at this time isn't lack of a plan or lack of nurses and other staff to administer this. It's the supply. I'll take that a step further and I'll say I'm proud that Reno County has such a wonderful plan. I think we are teed up much better than our surrounding counties and elsewhere. A lot of that is luck based on our size of 60,000 individuals, but our capacity from a healthcare, including the health department, that matches up quite well. The plan that Karen and the rest of the county team has should be a flip of a switch once we get the supply here. If we were to get more than 13,000 doses, then we really might be thinking, who can we push this out to help give all these? The reality is we will likely receive a supply smaller than that. And the difficulty will be which subset of these phases do we decide to give this limited supply to that will give our county the most bang for their buck. Bang for the buck in this case would be, who can we get this to that it's most likely to keep them out of the hospital and away from severe outcomes from the virus. That will be the most likely battle. But if we do get thousands and thousands of these, I would rather the issue be, we need a building big enough to do it. But again, that's unlikely. So locales will not be an issue at this time. It'll be the supply.
Hey, Dr. Polly, while you're talking, we have a question for you. Can you speak a little bit about giving the vaccine after treatment with the monoclonal, if I said that right, antibodies if someone had the virus?
Yeah, and I'll be honest, my information for this comes from Dr. Hartman, so you can tell where I learned most of my knowledge. We are advising at the national level, including the CDC, is to avoid the immunization for 90 days after the monoclonal antibodies. The target of the monoclonal antibodies is the spike protein of the virus. So we're hoping to neutralize the virus with those antibodies. But these vaccines we give work by having your own cells create this spike protein. So with the circulating antibodies in your system, it would largely negate the benefit that you would have. The thought is that those monoclonal antibodies that we give, again, in the summarized monoclonal antibodies, this is a IV treatment that we're giving to those who have mild to moderate COVID-19 but aren't needing hospitalization, with the hope of avoiding progression of their COVID-19 to the point that they might need the hospital. So long story short, a 90-day window after those monoclonal antibodies is recommended prior to receiving the vaccination. And Dr. Hartman, I might defer to you in case I missed something there.
No, that's absolutely correct. It's a theoretical concern that these antibodies that are given as treatment might inhibit the immune system from recognizing the vaccine and being effective. The vaccine is supposed to produce anti-spike antibodies, which is what the monoclonals are. So if you've already got these antibodies in your system, and you take the vaccine, your immunity may say, well, we've already got this and don't need to make any more. So that's a theoretical concern. I know if for no reason, it's not a reason to avoid taking the monoclonal antibodies. If you come down with COVID and you're in a high-risk group for severe infection, you should still take the monoclonal antibodies and wait to get the vaccine later. If you've had COVID infection without the monoclonal treatment, while you still may be immune from further infection for at least 90 days, it's okay and probably preferred to go ahead and take the vaccine if and when you can get it. Go ahead and take. I encourage everybody to get the vaccine at their first available opportunity instead of waiting, because it's probably never going to be more convenient to get than right now whenever you're in a group that it's offered to. Later on, it may be more sporadically available and we're not sure where it would be available. Just on a personal note, I did come down with COVID in November. Coincidentally, at the same time, these monoclonal antibodies became available. So I kind of used myself as a test case for our hospital to receive the treatment. And I'm glad I did, but for that reason, I'm still waiting for my 90 days to expire so that I can get the vaccine.
Thank you. That was actually going to be my next question for a personal reason as well. We did get a couple questions that aren't necessarily related to the vaccine, but COVID-19 infection itself. And maybe Amanda can speak to this too. Are you seeing any kind of complications still lingering, even neurological effects from those that have had the virus?
Probably one of the physicians would be better to answer this question because they may see them more on the outpatient than what I get to see them here at the hospital. Most of the ones that we take care of, we get discharged as best as we can. And I know that there's a long road to recovery for a lot of people, especially the ones that are pretty seriously ill. But I haven't seen as many that come back with other symptoms from our standpoint, but the physicians may be able to weigh in a little bit on what they're seeing in the outpatient side.
Also, go ahead, Dr. Hartman.
No, I was hoping you could take those because you see a lot more of these people post-infection than I do.
We do, and it seems like those with more severe cases of COVID-19 tend to be the most likely to have the complications and sequela afterwards. What we see most common if somebody doesn't make a full and quick recovery is prolonged fatigue, exertional shortness of breath. Many say that their stamina isn't quite what it was. There are some very specific findings that are mentioned in the literature that aren't worth going into a lot of detail here because those are much less common. But this virus does take a toll on portions of individuals' lungs. And for those who are having post-COVID, meaning after recovery, shortness of breath, we're seeing some findings that are very similar to other chronic lung diseases that are out there. Whether these individuals will have just a very drawn out and progressive recovery, we don't know, or if this will be lingering symptoms they have long term, we also don't know. The hospital does a wonderful job, and this includes the entire hospital team from Amanda and her team, and Dr. Hartman to our intensivists do a wonderful job getting individuals to a point that they can go home safely and get out of the hospital. We find ourselves doing things that we haven't done in the past, like discharging people back to home while they're still on oxygen. Classically, that's something that we might keep a person another day or two for, but to get some of these individuals off oxygen, it might be another week or two. And these are individuals that have been in the hospital for quite a while. So on the outpatient side, we have developed a pretty rapid and robust post-COVID follow-up. These individuals need closer monitoring, closer care than we would typically have otherwise. So we've enlisted the help of home health agencies when we need it. Those would be nurses who are able to visit these individuals at home. But also we've been using a lot of telemedicine simply to check in. Again, this is not called a novel virus for no reason. It's novel because it's new and we don't know a lot about it, and that goes for all of us. We now have about 12 months of knowledge in our back pocket, and we've learned a lot more, and the care has advanced, and I anticipate that it to continue to advance in the outpatient setting once people are recovering.
Thank you. Or is there anything that we haven't covered you would like to speak about?
I'd like to mention one thing for those persons that do get vaccinated. I would encourage everybody to sign up for the Vshare program, which is an app on your phone for monitoring and reporting side effects. You should get this information with the paperwork that you sign before becoming vaccinated. The CDC checks in once a day with a text message on your phone to check for side effects. And I encourage everybody to do this because that's the way we learn about what to expect in terms of safety and the adverse reaction profile. And even if you don't have any side effects, it's helpful for them to know that so that we get an idea of what the true incidence of side effects are.
And I would like to really advise people to reach out to your family, coworkers, others in the community who aren't able to listen to this. Please give them some advice, education, maybe if something we said here calms somebody's fears. We would like for that to happen. There are subsets of our population that it's been well proven are more skeptical of vaccinations and also less likely to seek medical care. We really need all corners of our community to be aware of and have access to this vaccine. And unless the knowledge is out there, we can't ensure that people have the ability and are without barriers for getting it. So I'd just like to push that message out there for everybody, and please help us do our job as being advocates and educators. Everybody in the community can help with this.
I do have one more interesting question that just came through. I, for one, am ready to travel. So Tim wants to know, the US is now going to require a negative COVID test within 72 hours of departure from a foreign country. If someone has already been vaccinated, would that pose a risk for testing positive with an antigen rapid test versus a PCR test?
No.
Our answers are equivocally no.
Thank you.
But again, it's still possible, even if you have been vaccinated, they may still require testing to find out if you're a carrier. So just showing a vaccination card may not be enough for some of the carriers, some of the the commercial carriers to let you fly. You may still need to be tested for the COVID virus itself.
I'll use kind of a real world example of one of my colleagues who has no problem with me sharing this. He did receive the first vaccine. In between his first and his second, he had a very close exposure in an emergency setting with a COVID positive individual. So he developed symptoms and he tested positive. There was no way that positive result had anything to do with his vaccine. It was positive because he was now infected with COVID-19. Both he, both I, both every other provider didn't have a single doubt in our mind that the vaccine would have triggered that positive. It's a scientific impossibility, not just an improbability. So I want people to know that, because there's going to be conversation out there that this vaccine caused it. One, this vaccine cannot cause COVID-19. It doesn't actually have the virus in it. Number two, it will not cause a false positive result with the test.
Good information.
Unfortunately, we're in the middle of a pandemic, and there's a lot of transmission in the community right now. So it's just predictable that many people at the time of getting vaccinated, either their first or second shot, have also become exposed to and infected by the coronavirus coincidentally. So I've been hearing of many people that are testing positive for COVID after the first or second shots. And it's just bad luck or coincidence that we got both infected and vaccinated at the same time, but the two are not related. This happens with influenza every year. People say, oh, I got the flu vaccine and then I came down with the flu. Well, we give flu vaccine during flu seasons. So sometimes people will get the vaccine at the same time or coming down with an actual infection. So again, one does not cause the other.
Karen, I'm going to ask you one more time, and you may have explained it, but we're getting a lot of questions on what qualifies as a high contact critical worker in phase 2. Can you go over some examples of that again? We have massage therapists, teachers that are asking if they qualify.
So yeah, we have worked as a medical collaborative to kind of narrow that down, and that phase 2 could have the potential to have up to 21,000 people that we've identified. Now, we in the medical collaborative have really looked at that 65 and older group because we want to keep them out of the hospital. And it's going to just depend on how much vaccine we get in. So we will get to those other high risk cohorts as fast as we can, but we certainly want to target that 65 and older group, because that is the group that we know is going to have the most devastating effects to that. So it's not saying that no one is more important than the other. It is just trying to protect our community and our hospital, and those that are most vulnerable for it. So I think there's an argument when you're looking at essential high critical workers that we could name almost anybody in that. And we are working to kind of identify the highest risk group in those cohorts though.
I'll add to that. Maybe I'm less cautious with my words. Karen does such a great job. We did not choose the wording in that document. That comes from somebody else. So I don't know if a true definition for that phrasing exists on who is included. And I'm not sure if the intent from the levels above us was for us to define that, or if they have some definition that we're unaware of. But I will say that in that higher risk 65 and older group, there will be some teachers, there will be some massage therapists, there will be any from across the board. So no matter your career or your contact, et cetera, if you are higher risk, you're higher risk and you're going to fall into that 65 plus subset. Once we exhaust that 65 plus subset, we will need to get better at defining those subsequent phase 2 groups. We haven't opened up that Pandora's box because we're not there yet. And a lot of it depends on supply, et cetera.
Okay, thank you. And I think we've got time for at least one more question, and here's a good one. We've been hearing that perhaps side effects with the second dose are a little bit worse than the first dose. Could someone explain what might happen?
I can start with that. The first dose is useful in essentially priming the immune system to recognize the antigen and develop the cellular processes to produce immunity. The second dose is needed to refine immune response, to invoke all the different lines of immunity and fine tune them to be specific for the virus. So after the first dose, the immune system's kind of primed to recognize this antigen, this attacker. And with the second dose, then more immune response is brought to bear. And so it's expected that there would be more of a reaction. And so yes, this is a common scenario. It's expected. The second dose may elicit more symptoms than the first. Most of the time, these symptoms are very short-lived, matter of hours, 1 to 2 days at the most. So we've cautioned people to try and keep that in mind. That may not feel very well. Sometimes they may have to even miss work. We try to stagger those groups of people in the hospital so that we don't have several people in the same department getting the second dose at the same time, just in case some of them don't feel well enough to come to work. So these are considerations everyone might want to keep in mind. But again, I would not be so worried about it as to either miss the second dose or miss the timing or delay in any way receiving the second dose, which is, we think, extremely important in getting the effectiveness of the vaccine up to the 95% level and for the durability of the immune response to make sure it lasts as long as possible.
Okay, does anybody else have anything they want to share? Amanda, I feel like I've left you out a little bit.
No, that's fine. As far as the response, Dr. Hartman is right. And what we've seen from our first dose and second dose is very consistent with what he said. And that's what we've seen from our staff. And most of it is short-lived. Most of it is quick for people. We've had a few that were a little more significant, had to miss a day here and there. And we're planning accordingly, just like you said, as we continue with this, with the second doses. But I agree. Don't let it be a deterrent in getting the vaccination. I think it's important. I think it's important. I know it was important for me, and I know it's important for a lot of the staff here that we've been able to vaccinate.
Okay. Any last comments?
I just want to say again, thank you to everybody. I know that we as Reno County have asked you guys to be on this panel and have asked so many things of you as you're practicing as well. So once again, such a huge thank you to you, Dr. Polly, and you, Dr. Hartman, and Amanda, and all your staff at the Hutch Regional Medical Center who have really been through everything at the hospital and treating patients, and our heart goes out to you guys, and we want to help with this phase. We're doing anything we can to help you guys. So please take your immunizations, and please help the hospital out and those working on the front line. So just thank you.
It's also
Likewise, and a lot of great questions.
Thank you.
okay. And thank you, viewers, for spending your lunchtime with us. Please be sure to check our website at renogov.org for updates on the phases. And we might plan another town hall here in the future. So thanks for joining us.